start, I have Dr. Charles Meakin with me today, who has over 33 years of experience treating cancer patients using standard of care protocols and cutting-edge metabolic strategies in cancer care. Dr. Meakin worked at hospitals, private clinics, and most recently served at United States Care Oncology Clinic branch as a chief medical director there. He left there and now he has his clinic, which is known as Meakin Metabolic Care, where he uses effective and well-tolerated integrated modalities to support and or complement standard of care treatments and improve overall outcomes for the patients. So the topics today that we'll be covering is what is metabolic therapy and how is it being used to treat cancer, integrative standalone applications in metabolic therapies, successful metabolic therapies used in practice, the role of diet in metabolic oncology, and repurposed medications in metabolic therapy, which are the most effective for cancer treatments. Also, he'll share some insight from research in his clinical work. So we'll just start off with, if you want to give a brief overview of anything I didn't share about yourself, Dr. Meakin, before I start asking you some questions.
Yes. So thank you, Peyton, and it's wonderful to be here. Happy New Year, and thank you for spending some time to hopefully pick up some information that can help you and your family or other people you meet along the way. I'm 65. Actually, I turned 65 today. So in 1989, I finished residency out of Stanford, was a board certified radiation oncologist. I was always sort of in the, kind of Eastern medicine, Western medicine world. As a teenager, did martial arts and was a weird kid who studied yoga and, thought about, in college, I was sort of I tried vegetarianism for a while and looked at diet as an impact in health and whatnot. But as a new doctor in the early 90s, I guess, I always felt like, we're not addressing some of the other fundamental issues in people's health. And that became more of a powerful drive as I worked initially in Cincinnati and then back in California, Northern California for just 2 years, and then primarily in the Charlotte, North Carolina area where my wife is from, and worked there from 1994 to 2019. So during that time, as a radiation oncologist, but always sort of the odd guy in our group that felt compelled to talk about things like sleep, like emotions, diet, hydration, pattern of breathing, spirituality, and some of the timing of the treatment with your day and nighttime cycles, and all these things that really weren't sort of guideline medicine for our field. Had the opportunity in 2019 to sort of go back and sort of reinvent myself by doing an entrepreneurial fellowship at Notre Dame, where you studied how to start business for science people, and a lot of computer science and engineering types there. And then I met Travis Christofferson, who, as you know, wrote the book Tripping Over the Truth. And he kind of had the same scratch the head moment. Why aren't we, embedding more metabolic strategies along with our standard of care therapies in the care of our cancer patients? And as some of you may remember, in I think it was 72, President Nixon at the time, stated the war on cancer and that we're going to figure this out in 5 to 10 years. And here we are today, where cancer is now soon to surpass cardiovascular disease as the primary cause of death. So Travis, I saw a lecture by him where the Care Oncology group, primarily was just in England at the time, had used simple 4 drugs that tripled the survival in a cohort of brain tumor patients, glioblastoma. And for years, glioblastoma has challenged we saw a lot of GBMs in the Charlotte area, and no matter what protocol we put them on or sent them to, the outcome was unfortunately, not so good. At times, I felt like standard of care was kind of just walking people off a cliff. So I always tried to get people to a Duke or UNC or UN, or we have a big hospital in Charlotte called Atrium, some sort of protocol or RTOG protocol, because I felt like the standard was just not doing it. And that was sort of a prime example, but there are other examples in standard of care. And so that's where I made the transition. And now, I work with Travis. He's a wonderful teammate and a science writer for myself. He's doing other things as well. And Meakin Metabolic Care kind of partners with Heal Navigators to try to bring kind of an efficient, it's totally virtual, so you don't have to drive anywhere. Low cost. We try to be low cost. Unfortunately, I have 45 state licenses, malpractice insurance, and other CMEs and things that still cost some money. And but we try to be efficient, affordable, and be cutting edge. So, that's how I see people virtually. And we use things that you can use virtually, like, it's not just about repurposed drugs. It's supplements, repurposed drugs, and a whole toolbox of lifestyle modifications that we can talk about and find the best access point for. And another big part of what we do here, and I think our nursing team echoes this quite a bit, because all of them are veteran oncology nurses with a lot of experience in other areas, end of life, research, cannabis, supplements, you name it. And another thing I think I bring to the table and our teammates as well is we can talk firsthand about a lot of the standard of care scenarios. And sometimes I'm pushing hard for people to pursue standard of care and not miss that low-hanging fruit opportunity. There are other times where I encourage people to ask critical questions, because sometimes the cost benefit ratio with some of the interventions are pretty minimal or modest, and you want to go into it with your eyes open. So I try to act as a sounding board, and I think you can do that having worked at a big cancer center, going to tumor boards for 33 or 4 or 5 years, whatever it was, and working with residents and so forth. So that's kind of what we do and how we do it. I think one of the questions was, what is metabolic care and when did it start? Or maybe go ahead, Peyton, start at the top.
Yeah, well, you started it off. So, Dr. Meakin, could you start by explaining like what metabolic therapy is and how it differs from traditional cancer treatments?
So it's not a black or white, yes or no, absolutist type difference. One would probably go back to the point in history and use the terms the somatic mutation theory of cancer. And that might, that engenders the thinking that most cancers emanate from a genetic flaw, a mutation that creates a clone of cells that bypasses the normal gates of kind of control and filtering, and takes root and grows. Versus the metabolic theory would be that at some point there's a loss of efficient metabolism, maybe, not so much fat burning to make energy efficiently, making ATP with oxygen, versus, using glucose, kind of a backdoor, um, using sugars to ferment and make ATP in a less efficient way, where there's a lot of metabolic smoke or ROS, reactive oxygen species. And when that happens, the regulatory processes to maintain the sanctity or the efficiency of transcribing chromosomes, you get flawed, transcriptions, and that in itself can lead to, abnormal cell growth, and so forth. So one kind of looks at, a genetic aberration as the first cause. The other looks at, faulty metabolism and the loss of regulation as the primary cause. That being said, in standard of care, there's been, there was, originally by Otto Warburg, the thinking that most cancer is a byproduct of poor metabolics in the cells. And there's studies along the way to suggest that got really out of favor in the 60s when, the whole genetic revolution occurred and, the whole genome was identified and reviewed. And there was a lot of excitement around that to solve the problem of cancer. But as we talked about earlier, we're seeing more and more cancers in younger people. And, although cardiac disease is being better managed than it was back years ago, we're slowly seeing, cancer mirror rate of death is cardiovascular disease. Now, especially, today we have what we think are 14 metabolically driven cancers, or what might be termed as cancers that are increasing in their prevalence, thought to be more from high levels of insulin growth factor and insulin, which is a byproduct of how we live and how we eat. Um, in the last 10 years, more of the targets for treatment have evolved to be metabolic. I give an example like everolimus is a mTOR mutation target, mTOR being the mammalian pathway proliferation. Two of our repurposed drugs, orvastatin and metformin, are also milder mTOR inhibitors. So a lot of the things we do work, push buttons and turn dials in the metabolic world. Some are repurposed drugs once again, some are supplements, some are lifestyle changes. So I would say in the last 10 years, there's been more attention to metabolic issues. And today, like, I'm a part of this integrative working oncology group, and we now have oncologists and researchers from the big universities. So I think it's that, we're seeing that turning point and more attention toward it.
Thank you for answering that. So how is metabolic therapy being explicitly used in cancer treatment?
So, once again, in the standard of care world, there are evolving new treatments that are targeting mTOR, that are targeting receptors on the membrane that pull in glucose. There's additionally some of the newer targeted therapies encourage or sometimes require that people be on a low carbohydrate or modified ketogenic type diet when they're on this, and it works a lot better if you're on it. If you look more toward people like myself, I think there's more of an acceptance when patients go into their standard doctor and say, by the way, I'm seeing a functional medicine doctor, integrative doctor, or somebody else that is suggesting I use some of these repurposed drugs that work metabolically to enhance the outcome with our standard treatments. And then there's the whole, opportunity I feel of sort of what I call metabolic priming, which means, when people go in for their infusion of chemotherapy or their daily radiation, using ketosis or some modest fasting with, exogenous ketones to make their normal cells more resilient to those treatments and diminish side effects, while also enhancing the cytotoxicity, making the cell kill greater. Cancer cells are more vulnerable in the state of ketosis. So there's some great opportunities that are pretty minimalistic. It's like just modest changes that can improve the outcome, because it's mind-boggling to think, but if you killed 5% more cancer cells on each chemotherapy or radiation dose, and you lighten the side effects by 5 to 10%, that treatment becomes so much more effective and a lot less toxic.
Thank you. Are there any particular types of cancer where using metabolic therapy is more effective?
Um, I would say that um, with the more severe cancers like glioblastoma, where our outcomes were not so good. I don't want to use negative words out there, but it was very disappointing for standard of care. And now we're starting to see that tail, instead of going right into the dirt, start to tail off, and the median survival start to move out too. In general, one would presume that the more glycolytic, the higher the SUV on a PET scan, the more sugar burning that cancer is, and that's usually true of like the hematologic cancers, like lymphomas, myelomas, things like that. They would be most impacted by, um, initiating additional metabolic therapy with it. I saw a person this week who, I think their tumor had a really high SUV. That's the measure of the uptake of glucose in the PET scan. And I mentioned that, that's kind of scary at first. Remember, those are the cancers that are going to do a U-turn when you shut the glucose down and you put up all these little choirs like metformin and atorvastatin with their fasting mimetics, along with, you know, say mebendazole, which also disrupts it. It's a mild glutamine uptake inhibitor. It's doxycycline, which disrupts it's a lot of things, but also challenges the mitochondria of these fast dividing acid area cancer cells. So it's those highly glycolytic cancers that I think get the most immediate impact. And I think it's beneficial in all cancers, and it's beneficial in you know you know chronic disease management. Remember, fat burning is our default energy production path, and so the more we sort of collapse back to that, the better everything is going to work, and the easier everything is going to work.
Thank you, Chuck. In your experience, how is metabolic therapy best applied as a standalone treatment, or is it best integrative? Because I have a lot of people that personally I even talk to that they don't want to do anything standard of care, and they're perhaps looking at metabolic therapies as a primary form of treatment. I know you've mentioned that it can enhance the effects of like chemo by implementing certain modalities, like say fasting or having a certain diet while using it. But can someone just use this as a primary form of treatment, or do you often encourage both?
So yeah, those are one of those questions where the devil's in the detail. Like, I'll give you an example of two cases. Um, Unfortunately, last week I saw this lovely couple, and she had developed a breast cancer rapidly in the after component of a birth and lactation, and there was delay because they thought it was more of a mastitis type problem, and this was a fast growing tumor in a very young person. And I really, as strong as I can, encouraged her, and then the husband was there as well, to pull out all the stops and use the best standard of care, even though the treatment was going to be difficult with upfront chemotherapy, with hopes for completion mastectomy, with hopes for chest wall radiation, and also integrate that with the best of metabolic therapy and try to get in front of this. Um, had I said, yeah, let's just do metabolics, we may have slowed it down. We may have, detoured it a bit, but the risk is too great. On the other hand, last week and probably every week, I see somebody who's dealing with a low gradish. I never want to diminish the emotional importance of any cancer, but a slower growing, say, prostate cancer. And some of the men have elected no initial therapy or what they call active surveillance. And that's a perfect time to say, all right, let's play with the dials a bit here. You may not be as optimized as you think. All this stuff we're doing is easy, cheap, and will make you stronger no matter what we end up doing down the road. And we measure that as we go forward. One of the tools in like the MD Predict or the CMOP is we do a big battery of labs, and also we do something called the pheno age, devised by two age researchers, Morgan Levine and Steve Horvath. And it kind of gives their biologic age alongside what we know to be their calendar age or chronologic age. And so we kind of get some feedback that, you know, internally, things we can't see using machine learning on simple blood tests, things look like they're working better. So, that would be a great time to start with standard, lifestyle changes and repurposed drugs, and know that we're not going to, get, end around, so to speak, or burn any bridges that we can't come back from. There's everything in the middle. And so, we do see some people who have already been through all the standard of care. Their local doctors or their doctors have said we don't really have more to offer, and then we do our best we can with non-standard of care. But usually I try to blend both when appropriate, like in the first case I mentioned. Sometimes you have the luxury of time to start with just one and see if it doesn't turn things around.
Perfect answer. Thank you, Chuck. Could you give an example of a case where metabolic therapy was successfully integrated with other treatments outside of just standard of care? So whether it be alternative treatments or whatever the case may be.
Yeah, so frequently, one of the discussion zones is, you know, can I feel comfortable not doing everything? There's so much out there. And, you know, as you might guess, there are, teasers out there all the time if you're sort of looking at things. And, people are trying to discern, do I need to go there and do some, all-inclusive, probably pretty expensive, away from my home therapy that, in some cases is, a blend of some standard of care, but also alternative care. Like I just saw a woman who's doing some, breast cancer therapy. She went to Germany. She's brought back a mild chemotherapy that you can do orally. She's doing it with, um, timing it with metformin. And she also does our repurposed drugs. She's also, done what I call modified. I, the I mentioned her. I mentioned their name and modified diet, which that uses low carbohydrates, some intermittent fasting, some exercise after eating, some supplements, some medications. So it's not an extreme diet, but when you do all those together, my belief, and I think some of the other metabolically minded nutritionists around feel like you probably get most of what you would get with an extreme ketogenic diet or more extreme fasting, and so forth. But anyway, she's kind of getting a blend, and I always caution people about chasing too much. We're tribal people were pack animals, so to speak. Leaving home to go someplace far away pulls you out of your comfort zone of your friends and family and maybe your pets and stuff. Secondly, there's stress with that living outside in a new environment and so forth. Um, our body is built to get stronger with certain sort of challenges, call those hermetic challenges. But just like a couch potato can't go out and run a marathon one day, you can't really just jump into supportive care like high dose vitamin C coupled with ozone or hyperbaric oxygen. All those are oxidant therapies. If you do too much or stack too many, it might be too much for your body and be counterproductive. So I try to sort of give people a blend of what's going to be right for them and how to time it. A lot of the data on high dose vitamin C supports the benefit to mitigate standard of care side effects and foster faster recovery. There's some data on improvement in outcome with a few of the papers, but mainly it's the former. And so I would encourage people to time it in a way where it's not as overwhelming and when it's blended in with the chemotherapy. It might be used where if they're on a chemotherapy, day one, and then sometimes there's an infusion that goes to day three, use that infusion vitamin C in say week 2, 3 for the next round of chemotherapy. And that seems to be more tolerable and more, less onerous on the scheduling. Once again, with the mindset that it will likely mitigate and foster some recovery, diminish risk of infections and things like that. And if it helps kill more cancer cells like it looks like it should in petri dishes and in mice, that's even better as well.
Thank you.
There's multiple ways to integrate it, and it's so so individual. But as I said earlier, sometimes I end up simplifying things for people so they don't feel so overwhelmed with all the different options.
And I think a perk too of working with you is not everyone has the affordability of being able to go to facilities. In my opinion, I do feel like they can be beneficial. It's like a boot camp for your immune system. And a lot of people do benefit in the way of just like kickstarting it for them to continue at home. But not everyone has, 18 to
Yeah.
45,000. And then if you're looking in the States, it's like 45,000 to 210,000. So it can get pretty pricey. With your program, it's, $950, for the 3-month commitment to start with. And then of course, medication supplements is separate, but it's a more cost effective way of treatment, in my opinion. So with patients that are now looking to bridge the gaps between standard of care practices and alternative options, what would your advice be to those patients who are hesitant to take like this leap of faith, knowing that their oncologist might not be supportive of these practices? Because I get this question all the time that, oh, I'll work with Dr. Meakin after I talk to my oncologist and get their approval. And I'm like, they're
Yes.
not going to approve it.
That I see it all over the map. And I must say though, now that I've been doing this since 2019, and I was sort of a little bit of an outlier in the 25 years I worked as a busy oncologist. I'd kind of have to, when I was director of the center, and I was a hardworking guy, and I was always one of the busiest, and you know didn't have any reason for people to complain, which made them a little more tolerant to the guy who suggested, changing the diet and stuff like that. But and also over time, you start getting some really amazing outcomes, and people are on board. But in the U.S., as see people in 45 states, I see the whole gamut. Some people come back and say, "My doctor says whatever help you can give, the more the better. Thank you." Other people say, if you talk to another doctor and don't do exactly what I say, I don't want you coming back to this practice. So it's sort of the two extremes. I remind people that cancer care is a service. It's a business, and that they're the customer. And yes, you want to, keep a positive atmosphere and whatnot, but you want to make sure you have a doctor that you can have a conversation with. It's usually hard to have a two-way conversation if someone is always got their hand on the doorknob or behind a computer or standing up in an exam room and you're, got a drape on or something. A conversation is face to face, same level. You get to know a little about them and they get to know a little about you. And if during that conversation you raise the issue that you think you need to do some additional stuff, the obvious answer would be, well, why would you do that if we're going to cure you? And that's where it comes up. Like if your treatment has a very low cure rate or a very difficult course for a little minimal benefit, then it's pretty rational to consider safe things, judiciously guided, not foolishly costly, that enhance the outcome. And that may allow that doctor to say, yeah, it's pretty reasonable. They're watching the liver function test, the renal function test. They're aware of side effects and treatment complications with different medications. Today, I wouldn't start a lady on dipritamol until she talked to her doctor about getting off Xarelto, a blood thinner, but she'd been on it for 3 years for a blood clot that's long gone. So there's good reason to talk to her doctor about maybe getting off of it. So those are the things that we can kind of bring back to help people move that conversation along. Most of the time, it works out. And so far, I don't think I don't think too many people have gotten in trouble with their local doctors. And I'm seeing greater acceptance of it if you look at it year by year.
Well, that's good that we're finally coming to that head then.
Yeah.
Is a concern always with patients that I talk to. They're worried about getting fired, not being able to, getting fired always. And I'm like, technically you hire them is my mindset. And I try to
Yeah, yeah.
that, into them. I've dealt that with even my own practitioners for my son, not having a like-minded practitioner. And I'm like, oh, I kind of hire you. So I'm gonna go find a different one. But they're worried about not being able to get their scans. How can I monitor it
Yeah.
if I don't have a practitioner, or maybe they're on some type of immunotherapy that's keeping it at bay and they're at a final stable place and they're worried about losing their practitioner. So it is always a concern. I always try to tell people that you can navigate those options with them, but just for the viewers, it's good to ask and have that answered for them. So let's move on to some success stories because these are always fun for people to hear and very motivating. So can you share a few successful outcomes that you've observed in your practice with metabolic treatment and therapy?
Yeah, there's, uh, you know, that's where that's one of the reasons I keep, enlarging and expanding and trying to be more involved in this is because you get, motivated by meeting these wonderful people um, that have ducked and weaved and figured it out. And to be a small part of that is exciting for me, and it kind of helps with personal missions and stuff like that. But one of the stories, and I won't mention any names, of course, but I think one of the stories that resonates with me that I won't forget is a mother of three young children, three boys, woke up after surgery and had a brain tumor, and of course was heard, "Hey, you did great. We got most of it out, or we got virtually all of it out. All we could see, everything went well." So then she got on Dr. Google and realized that like 95% of the people die within 2 years. And so at that point, she, said, I need to figure this out. And she started on a ketogenic diet through the good help of one of the well-known nutrition researchers and, people out there, Miriam Kalamian. I'll mention her name. She's remarkable. And then she ultimately got linked up with Oncology, and then ultimately she was on my docket, and I got the joy to get to know her and her husband. And she's one of the only people with a glioblastoma that I ever met that made to 5 years. And I was new into this at that point. And then I started seeing more and more people that didn't recur in the first year or two. And most of them did standard of care, but also dietary changes plus repurposed drugs. Some did Optune for a while, some did other things along the way. But that first case, this lovely gal and her husband and 3 young boys, was so memorable to me. Um, and that was sort of a big turning point. That's a brain tumor, colorectal. Another vital man in his 40s kind of had stage 4 colorectal cancer, went to the big hospital there in the Bay Area, place I'm familiar with, and got good chemotherapy, then surgery. He had 12 little nodules on the lung they thought were likely regrow as the chemo winded down. He was very disciplined and dove big time into he talked to another guy who told him about changing his lifestyle. And it wasn't just, exercise and how he ate, but I think a big part of it was sort of a kind of an emotional, spiritual component as well. Got him on repurposed drugs. Just recently heard from him. He's doing well. He's over 5 years out. Nothing's ever come back. And he, he's fitter and stronger than he used to be. And he was pretty good shape at the beginning of everything. Another case would be somebody everybody knows about that, is I think one of the more generous people, her and her husband, Maggie and Brad Jones. I got to meet Maggie very early in her, now very public discussion of her lung cancer. And she jokes about it. I mean, she said, on my 40th birthday, I got diagnosed with lung cancer. I never smoked. I had disease in my brain, my retina, my lungs, my abdominal, liver, and lymph node area. And she, started initially on like a tyrosine kinase inhibitor, and things progressed, and she also got radiation, but she then switched gears and started deploying metabolic therapies with the second line TKI, and usually that one doesn't work as well if the first one failed, but she's basically been stable on that for 4+ years. Her PET scans are clean. She's kind of dealing with some of the side effects of one of her aggressive SRS to the brain, but she functions better than 99% of the people in this country. You know, making a documentary on metabolic oncology, probably answering emails and doing a million things I don't even know about. But she's another screaming example. And those are just sort of lead discussion points. There's a lot of other people that maybe aren't as black and white, but instead of just responding for 9 months, they've responded for 19 months. But that gives them a longer time to kind of bridge to the next treatment. And while they're responding, hopefully they're doing some of the mantras that I sort of brat, that you got to have a litmus test to make sure you're staying the same or getting stronger. We got to, want to see your homo IR, your measures of efficient metabolism improve or stay improved. We want to see your superfluous inflammation diminish so your cancer can be fully targeted by your own T cell mediated immunity. We want to have efficient methylation in the body. We want to, get down to your optimal weight to the degree we can. So the more you sort of dial in for those, stronger you are for the next round. And every year, new things are coming out. But some of the victories are not as dramatic as the few cases I mentioned, but many of them are modest, and modest times 2 or 3 times can be pretty dramatic. Sometimes that's what we're shooting for. I grew up in Cincinnati. Pete Rose wasn't a home run king, but he had a lot of singles and doubles, and that's what we're trying. A lot of singles and doubles. I won't talk about his gambling habits, but for those of you who know baseball.
Thank you, Chuck, for answering that. So what are some challenges that patients typically face when undergoing metabolic therapy, and how are these addressed? Also, I see all your questions that you guys are submitting. Keep them coming, because we will have like a Q&A portion. I have a few more questions to ask, and then we'll get over to the questions that you guys have been submitting. I just wanted to acknowledge that, because we have a chat going on in Facebook.
Sure.
And they've been pretty active. You got some happy birthday wishes too, by the way. So,
well, thank you. Thank you. 65 gives me 2 clubs I get to join. One is Medicare. The other is my mom used to joke about this. You can now remove the filter and be more direct with people.
that's my favorite.
That may get me in trouble, but no, I think, as I alluded to earlier, some of the challenges are trying to sort of filter the noise out. There's so many things coming at you, wonderful people, and I try to major in the majors. Like today, there was a request, and I hear this and see it and understand it about doing. We have like what we call the predict panel, but they wanted to do a lot of the other lesser, common nuance type, labs that would probably triple the cost to them. And we would also have to individually put those on. And I kind of said, well, let's get the major ones. Because usually between our onboarding questions and this predict panel, or the labs that we get in the CMOP. Now, people, if they can't get the common tumor markers or some other things, we can add those pretty easily. We do them at a very low cost, because it's a busy practice. I get stuff from Quest very low cost, and we still have to have wonderful people like Peyton and Taryn and Michaela and others to sort of onboard the people and get the requisition slips where they need to. But a lot of times it's a matter of like, all right, let's major in the majors. If you're not sleeping well and you're upside down there, we want to get that right. We're not going to worry about the genetic sequencing of your microbiome right now if some of these common things are not, not perfect, but what I call above average. And so we try to focus on the big things. Secondly, we acknowledge that you can't do everything. You can't even do half of it. But let's figure out what the sweet spot is for you and sort of commit to that, and then to your left and right if we don't see results. And like what I do in my repurposed drug protocol is not try to add 8 to 10, 12 drugs and supplements right off the bat. I try to add I look at safety and tolerability and add those. And that's kind of like the scaffolding. And then we add to that every month, 2 or 3 months, we see each other depending on tolerance, depending on laboratory feedback, the safety labs, it's like $25 worth of labs is pretty low cost. And then also, and most people get those too with their general physician, and then add additional supplements as we go. So we start small and add, as opposed to starting big and pulling back. Um, the other challenges I think would be the the having this sort of calmness or stoicism to stay calm through all this period of time when you're getting a lot of different feedback from friends and even doctors. A lot of times I speak to people about nutrition, and I don't get into the weeds as much as somebody who is an expert at it, like, as I mentioned earlier, Maren Kalamian and her team. But in the debate of what is the best anti-cancer diet, I frequently come down, and some people out in the blogosphere may not agree with this, but I kind of say what I know today, which may change tomorrow, is that you can't live too long without clean fats and proteins. Fats build the brain and the lining of our nerves and a lot of other membrane type important features. Protein helps our structure, our immune system, uh, neurotransmitters, you name it. But we can get by on lower carbohydrates. And unfortunately, most plant proteins come with carbohydrates. And so, I would prefer to have people on cleanly sourced animal proteins with some intermittent fasting, with some blend of exercise after eating, as long as they're not cachectic or low on their weight in a dramatic way, to maintain their structure and their muscles or avoid sarcopenia, and then use repurposed drugs and supplements with that. I think that mirrors most of the metabolic minded researchers out there. Uh, and so sometimes that's at odds with what people have been taught. Like last week, a gal came in and she's saying, "Hey doc, I'm doing the anti-cancer diet. I'm juicing 3 times a day with a lot of fruit and beets and carrots, and I'm pretty much off all meat. But I'm eating a lot, and have indigestion a lot, because I mean, if you want to sustain yourself on just raw vegetables, you almost got to pull up a pickup truck." So anyway, she was getting a lot of raw fructose, and she was progressing when I met her. So we had to sort of talk about that and sort of talk about the challenges of knowing what's a good idea out there. I'm a big advocate of vegetables, cruciferous vegetables. I call them fat carriers. You want to line them with olive oil, coconut oil, or avocado oil, and they're the Trojan horse that brings that fat into your body. Um, but anyway, I have people that come in, and I got to speak up and say, hey, to my knowledge today, that is potentially driving your cancer as well. So sometimes there's conflicting stuff out there. It's not as black and white as people think. And I'm
Our
going to
bodies
talk.
aren't black and white, though.
Yeah,
Also
yeah,
different. What works for some isn't going to work for others. And
yeah,
metabolic approach is completely different than Gerson approach or Budwig approach, or so it's all, or Chris B cancer protocol. You got to figure out what works for your body, but there's a lot of sugars and carbs and stuff too. And if you're doing the metabolic approach, then that's gonna throw
yeah.
it to one skill than the other. Yeah, you are right about that.
I heard a talk by Ben Bickman, who's a wonderful researcher on metabolism out in I think Utah, and he said, certain like amino acids like glutamine and methionine, they bump mTOR up for about a half an hour, in a standard meal type presence of it. Whereas, the typical fructose, sucrose, tose, sucrose, glucose combinations, they're going to bump up blood mTOR and activate it for like 2 to 4 hours.
Mhm.
So there's variable, I mean, there's some truth to certain things may activate mTOR, but the degree is kind of what we're talking about. And as we've talked about, it's hard to live too long, too well without reasonable protein. So, I'm looking forward to the Metabolic Health Conference in a few days. Maybe we'll find out some new information. But once again, sometimes there's controversies out there, and you got to come down on what you think's best for their health. Sometimes it's at odds with what other people have told them.
So how do you play in regards to Thomas Siegfried, Jay McClellan, Nasha Winters? That's always a question. People like, will he do Thomas Siegfried's protocol, or will he do Jay McClellan's protocol? They want to do it by the book, or maybe I spoke to someone today, she had mapping done, and she had, a certain amount of certain medications that she had questions. I did send you an email, by the way, about this a certain patient,
Okay.
and she answered today. But she was asking this one in particular about like, will he prescribe XYZ medications? So how do you relate in regard to that research? Because there was a question where someone was asking about DON, for instance, DON medication, and Thomas Siegfried's thoughts about that and how it works with the
Yeah.
metabolic
So,
genetic
and, and,
diet.
and first of all, I have a lot of respect for all the names you mentioned. I think I'm a friend with all of them. I hope to see Thomas Siegfried at the Metabolic Health. I think Jane told me she's going, and I haven't spoken to Naisha just recently, but she's usually there. And boy, what a great teacher and energetic survivor and wonderful person all those are. But I gotta take care of people in the zone of my world. So we don't have like an infusion lab. I take care of people virtually, and like things like Dawn are really not available in something I can give to a patient. I've looked into it before. You kind of got to get it from like an industrial chemistry sale place. And I know it's been used a lot in animals, and maybe there's back off. I mean, underground ways to get it, from other countries, but can't really use that in my normal practice. And maybe someday that will change. So I have to use alternatives. Secondly, Jane does a great job at describing the Metro map and all the different pathways that can be usurped by cancer cells and whatnot. But to safely sort of start with care, we kind of start with a core 3 to 5, and then build from there. And so while we test bloods and so forth, in addition, there are some meds that are available in England that aren't available here and so forth. Um, with Naisha, I know, some of her programs emphasize a lot of, deep, extensive testing on, say, heavy metal, mold toxicity and drivers of that, GI, microbiome sequencing. I tend to start pretty low cost because I want to be sort of a
All that can get
potential.
very expensive.
Yeah, yeah, all that is, you can rack up some money. So
Yeah.
I kind of, as I said earlier, I like to major in the majors and figure out if we can find flaws in the easy to find things.
Mhm.
And then if people have lingering issues that we're having trouble with, uh, we can fix it. And like instead of doing, you know, genetic, uh, 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 looking at, genetic weakness and methylation, we just check an homocysteine. And if that's elevated, we fix that with methylated B vitamins, and we use a product that also has other things to lower it, and make people aware of the issues around that. So as I said, we find a lot of the problems without doing the $2,000, $3,000 test. That being said, I'm going to start working with a company called Datar Genetics that is kind of newer to this country. They still process most of their labs in England. But they're moving some of that work to the Raleigh area, to the Triangle area there in North Carolina. They have a blood test that some of our patients and family members would benefit from. It's called Trinetra. It looks at circulating tumor cells and can back estimate the organ. And if they can't figure out where these cells are from, then they'll do more testing on a serial basis at no cost to see if they can capture it. Right now, to send everything back, it's probably going to be about $1,000 test, but it's validated on about 80% of the cancers that strike men and women. So that will be a dramatic improvement from the screening tests we have today. The second product they have is called ChemoScale, where, like you alluded to, they do circulating tumor cell acquisition. They plate them out. They test it with the common repurposed drugs, the common supplements, and give you like a cell death rate from a 12-hour exposure. And they're very flexible and will even allow us to sort of add certain repurposed drugs as an option to be tested. And so that may help create a roadmap. And I believe this is much more
Cost effective.
validated and predicted than some of the other assays out there. Unfortunately, it's a $5,000 inquiry, just because they test it with like 30 things. And so we hope to see those prices come down. And then there is going to be some thoughtfulness that's going to be required. And I'm working on this with one of the prior care oncology doctors from England on how to integrate that information into the care of a patient. Because you got to think about their liver function. You got to think about the other standard of care they're on. You got to think about their simple things like body size and their functionality. And so how to best customize it to the patient. So I doubt we'll be seeing, just everybody throwing things at everybody. Like, recently I had a patient that was getting a very high dose of a product, and it was a little bit surprising. And people forget that, you can blow a liver from certain supplements and certain over-the-counter drugs, just
Yeah.
because it's quote natural or a supplement doesn't mean it's totally safe.
Yeah, everything's processed through there as well. I tell people all the time, make sure that you're checking your liver and kidney enzymes if you're not working with someone, even for supplements that you're working with, and to make
Yeah.
sure that your body can tolerate that. Speaking of supplements, someone was asking, what is your view on berberine in place of metformin, and view on citrus bergamot plus garcinia in place of atorvastatin?
So I think for berberine and metformin, I encourage people to use both. I think there's overlapping benefits. There's things they both do. Berberine does a little better job at directly dropping blood sugar. It also has some benefits as an anti-infective agent. It also maybe works is in some of the cholesterol pathways. Metformin has a better track record, and maybe some of the impact is on what it does in the microbiome. Some of the benefit may be how it works more upstream and make you more sensitive to your own insulin, and bringing down sort of the drivers of proliferation, insulin growth factor and insulin, which many people know, most cancer cells have those receptors on them, because most of our normal cells have that, and cancer cells are sort of a reflection of, a flawed normal cell. As far as the other two, I usually try to say I can't be absolute that it replaces it. I remind people that a statin is, we're not really pulling cholesterol molecules from the mouths of cancer cells to diminish their ability to use that to make other sterols and things like that. We're primarily downregulating mTOR and upregulating the fasting pathway AMP kinase. And the statin, especially at modest doses, does that pretty well. And then there's no reason we can't add in these other supplements to enhance that, as long as, once again, as you implied, sort of their liver, their digestion, their kidney function all, stay stable. I like all three of those supplements, and use them myself to some degree and advocate them in certain patients. So it's not an either or, and especially with difficult cancer, I like the cocktail effect where you use a little bit of a lot of things.
Mhm. Cover a lot of bases. Somebody said that a friend's chemo has damaged cells that help her get nutrients. She's getting nutrients through IVs. Doctor said it may take 3 to 4 weeks for her cell to recreate and work to provide nutrition. What could be done to encourage these cells to grow? And I'm gonna do like some rapid fire questions, just so you know.
Yeah, so if you've kind of stripped I think the question, she's had like severe trouble with her intestinal lining. You can see that from idiosyncratic reaction to chemotherapy or big radiation fields, or if you had one of the itises from one of the immunotherapies and get a colitis, you really get in trouble. Unfortunately, the old treatment for that was high dose of a certain amino acid, glutamine, and they used to give it with make glutamine powder, and that activates GI metabolism and helps heal things. It's also thought to be sort of a signaling molecule that cancer cells respond to and may activate proliferation. And I'm always weary and concerned about adding that in that situation for the cancer activation concern. If someone is sort of in a, life and death situation because of the GI tract, it's probably an easy choice to kind of go with the glutamine slurry in addition to other things. I like aloe vera on as a daily elixir.
Hmm. I
It's
use
very
that.
healing. Yeah, yeah, and I like
My thyroid. It reduces thyroid antibodies.
really, really
Yeah.
well. I use it every morning. It's I like a lily of the desert, the gel full fillet formula.
Yep.
Use about an ounce or two in the morning water, and it's first thing down the chute, and it hits a lot of the GI tract and heals. I healed a little bit of a EGE junction, Barrett's esophagus with it years ago. I just kind of knew intuitively taking an acid blocker indefinitely was not a good idea. Um, in addition to things that would heal the GI tract, hyperbaric oxygen is sort of the Swiss Army knife. It helps oxygen get to areas of diminished blood flow. It helps heal virtually everything. It activates stem cells. It oxygen is sometimes the weak link in the healing or the recovery of certain things. So that is becoming more and more available through wellness centers and so forth. So I would say some blend of those three, coupled with some, the easiest elemental protein you can get in. I like a product called Perfect Amino. I'm sounding like a commercial. Here it is. It's the essential amino acids that your body doesn't make,
Yeah.
and they're in elemental form. So the body doesn't have to break it down to get to it.
Yeah, I take some amino acids by like Purium. And also Thrive Market, not trying to be an ad either,
Yeah,
but I use that a lot for like my own groceries and my son's snacks and stuff. They have the Lily of the Desert brand on there for the aloe vera, and it's like $6.99, or like you save a tremendous amount because at Whole Foods it's like $12 or $9
yeah. And
for.
I hate to say it, but I buy it in the gallon.
Oh
And
yeah,
I, because it is so big and dominates your fridge, I have four like 16-ounce bottles that I then
like the little
distributed
glass
to
one.
and then hide it, you know. But the gel formula, I think, works better than sort of the juice or, filtered formula. Uh, and it's kind of chunky when you pour it out. It's that's one feedback I got from patients over the year. They say, Doc, sure you're a smart guy, but the smartest thing you ever mentioned was that aloe vera. It healed my husband's throat after head and neck radiation, or
Very
my
soothing.
yeah.
I did go ahead and drop Dr. Meakin's link for the repurposed medication program that he has on Pill Navigator's platform. I as well will link his website too, because he does have like the predict panel on there. I will be posting my call link too. If anybody has any questions about his offerings or to connect with him, you're more than welcome to schedule a call with me. I'm always here to answer any questions. If I don't know them, I will ask Dr. Meakin directly. Him and I are in contact all the time. I know there are a lot of like specific diagnosis questions. We just unfortunately don't have time to answer all the diagnosis questions. However, I know blood cancers, it's always like a big concern because they're handled a little differently than like, solid tumor cancers. So there was quite a few about that. Also mantle cell, which is pre-cancerous. So people were asking if you do work with that. And I said yes, because I do know from asking you in the past about mantle cell that you did. So just to acknowledge that I did answer those in the
Okay. Yeah,
chat.
we just saw somebody with mantle cell lymphoma like 3 weeks ago, 4 weeks ago, and so if somebody's on like a very regimented pediatric oncology leukemia protocol, and it's going to be super intense, and they're going to push people to the limit and then live in the bubble in the hospital as their immune system recovers. And I don't usually try to suggest we should intervene then, but then in the after recovery, after the blood count recovery, we then consider repurposed drugs and so forth. This goes along with multiple myeloma as well, some of the chronic lymphomas. Um, and so, like, I think next week I'm seeing a young person with a follicular lymphoma who's in that zone where they have the lymphoma, but they're going to monitor it for a while before they jump in. That's a perfect time to, you know, turn all the dials and change the lifestyle. And to mention what, to kind of dovetail on that, everybody comes to us at different levels
Oh, you froze, Chuck.
of commitment. Of course, some people just want my website and be seen tomorrow. That's like, I think $250 for the first visit. Some people don't need, detailed nursing care. And so they would just do the doctor visit, which is a longer visit because we put all the stuff in calculators and then discuss it. That's the MD predict. And then the full program for those who want our excellent nursing support with with certified nursing, oncology nurses that all have integrative backgrounds. That's the cancer metabolic optimization protocol. That's a kind of a quarterly, more expensive program that includes all the labs. So that way people can pick and choose what's right for them.
Yeah.
Always know that from a doctor standpoint, if anybody is low on their dough, after we first see you, and if you're, I don't want anybody missing lunches to see their doctor, so we can drop the cost if that is a true issue. And so never doubt that.
Somebody did ask about the amino acids, and just like two more questions, and then we'll end up ending it here because we are getting almost to the half hour. They said, can we take perfect aminos with cancer metabolic protocol? I stopped because I thought it would add glutamate.
Yes. So remember, there's debate on like how many true amino acids. Some are like pseudo amino acids. Most people say there's 21 or 23. And then there's 8. A little debate there. Some people say 9 that the body doesn't make from other amino acids and protein breakdown products in the body. And of course, if you need to make a certain protein or nucleic acid that requires certain amino acids, and you don't have that, your body's going to be, unable to effectively make certain things that it needs. And so, plant proteins, animal proteins all have some percentage of many of the amino acids. Yes, plant proteins have, in general, some lower percentage. They still have them of, say, glutamine, uh, methionine, and things that are thought to be activators in certain cancer cell metabolisms. But they still have some of them. And so, as I said earlier, you can't really get in a total chicken fight with your body. Your body still needs to maintain all its important functions. And I think perfect amino is a great way to get it because it doesn't have to have a good acid environment in the stomach to break it down like it would like with a plant protein or an animal protein. It just breaks down into the little pieces right from the start, and then it's readily absorbable and it fills in all the missing gaps. So it's great for people who are struggling to regain vitality and weight, people on a vegetarian or vegan diet where there may be some diminished availability of the essential amino acids. I use it even when I fast. So if I'm only going to eat dinner, lunch and dinner, if I do a big workout in the morning, I'll do like this morning. I did 5 perfect amino tablets. It's easy to do, and I feel like the activation of my muscle system will still allow to assimilate those amino acids to maintain and hopefully grow, despite fasting through the day. Usually 5 to 10 grams of a protein won't trigger an insulin reaction by most people's measure. You can always measure your own blood sugar and see what it looks like. The key thing with modified fasting is to not trigger an insulin event. And very low dose protein generally won't do that. And of course, carbohydrates will do that. So I'm not worried about using a perfect amino in the background of a cancer patient.
Thank you. And for the last question, ivermectin, it's ivermectin, pipendazole, it's always commonly asked, but they were asking about the lactoferrin and ivermectin. Can you comment on its use together with lactoferrin, which increases IV and ivermectin effectiveness? Is lactoferrin safe for estrogen-driven cancer? And that would be the last question for today.
The lactoferrin component to that, I'm not sure I can answer that. I do, add ivermectin to some of the cancers. One of the problems I have right now is, I pulse it because there's a bit of expense to it. Getting it through compounding pharmacy in a dose that we use for cancer, usually in the 20 to 40 milligram per day, starts adding up if you use it daily or 3 times a week. So I tend to pulse it, 1 to 2 times a week. Usually also people getting mebendazole or taking fobendazole on their own. In this country, we don't usually use too much albendazole. However, that way I think there's some overlapping features to ivermectin and mebendazole, but there's definitely some independent features. And so we're seeing a lot of use for it. a lot with, say, some of the adenocarcinomas like colorectal, like prostate, like other GI cancers. Plus, like mebendazole, ivermectin, I don't see a lot of side effects from it. Knock on wood. Taking it myself for, experimentation and for COVID prophylaxis and things like that. And, to me, it's tolerated better than maybe aspirin and half a Tylenol. Um, I've used it in breast cancer patients, not first line. I've used it sort of probably, like second tier or maybe third tier when things are progressing, and or if they have other reasons to use it, like recent COVID or something like that. Some people will respond, or Peter McCullough, to re-challenge them with COVID, with ivermectin if they are having, sort of lingering COVID symptoms.
Thank you, Chuck, for chiming in on that. I just wanted to answer that one last question for someone. I did answer some questions to you guys in the comments. The person that was asking about ileostomies, this is okay. I've asked this before in the past. It does not affect the treatments. Same if someone's on Eliquis, you would just disclose this during your onboarding, and Dr. Meakin would overview that and customize your protocol to your needs. But I appreciate you, Chuck, for holding the space and tuning in today and supplying all your knowledge to everyone that tuned in. We had a very active chat with a lot of questions.
Yeah,
I'm sure that I might be getting some calls, so I'll be sending you some emails if I don't know some of these
sure.
questions that they
And,
might
and,
ask me.
and thank you for, hitting the highlights so well as you always do, Peyton, and being sort of the never too early, never too late teammate that I can, ask for some help on something. And unfortunately, some patients kind of email in, and I always feel like I'm, taking the easy way out. It's like when you
You do
call
your
your
best, Chuck.
doctor
You do your
and
best.
they say, if this is an emergency, call emergency, go to the ER. It's like, well, that sounds official, but it's a blow off, But
Yeah.
anyway, it's hard for us to really give medical advice without having consent in place and stuff like that. And secondly, sometimes there's a battery of multiple questions. And, I work most days of the week and, pretty busy, and we really can't ask or answer, multi-page emails and is sort of a before we see you. We really need to like,
It's always best to have someone's medical records in front of you, as
yeah, yeah,
well as all the medications someone's on, treatment, current protocols, all that. By answering one question, I mean, you could say yes to something, but then later on it could be a no once you further look into the case, so it's easier just to schedule a consult. Even like I had a few people that were questionable about doing like the bigger commitment, and I said, do a quick consult first, test
yeah,
it out, dip your toes and see if it's right for you. That's what those quick consults are for, to just like an introductory process, rather than doing like predict panels, spending more on that, or, on like the CMOP or advanced metabolic program. So,
yeah. And we generally go more than 30 minutes. And
yeah.
my goodness, you can't get an electrician or a plumber to come to your house for less than $200. So
And you're very personal, Chuck. You have a great personality. I always remind people of that too.
sometimes I'd rather see a plumber than a doctor, but when you need them, you need
Yes.
them. Anyway, it's nice meeting everybody. God bless. And thank you, Peyton. Appreciate it.
No, thank you, Chuck. And we'll talk soon. I hope you have a great day. And happy
You bet.
birthday.
Going out to dinner tonight.
Yeah, enjoy yourself. Enjoy
All
yourself.
righty. Take care.
Bye.